Hi everyone, welcome to today's episode of OBGynugget. And the topic for today's discussion is going to be a very interesting one. It's a topic that we see quite often in our outpatient department, in our admitted patients, but we don't really know much of it. And we often seek the help of our friends from dermatology to guide us on it. And I would like to offer some insight into the topic today to you all within a brief amount of time, within a short amount of time through this OBGYN nugget. So the topic for the day is going to be skin lesions in pregnancy, or what we also call as obstetric dermatosis. Before we proceed with this chapter, I would want you all to understand a few terminologies when I'm talking about dermatosis. So the first one is, what's a papule? Secondly, what's a plaque? Third, what's a macule? And lastly, what's a bulla? There are many more terminologies, but these are the main ones that I would want you to know. So a papule is anything, imagine this is the surface of your skin, anything that is raised, so elevated, less than 1 centimeter diameter lesion. Whereas a plaque is something similar, but it's a more than 1 centimeter elevated plaque. So everything is the same, it is just that it is more than 1 centimeter diameter lesion. What's a macule? A macule is something again very similar, but it is not elevated and it is less than 1 centimeter. So something that is like this. ये रेड पेन से करता हूँ, ये ऐसे. So something like this. So a flat, less than 1 centimeter diameter skin lesion. Whereas a bulla is a watery lesion. पूरा इसमें पानी है, which is more than 1 centimeter. If it is less than 1 centimeter, it's a vesicle. So a water or a clear fluid, anything water filled or a clear serous fluid, serous filled, well circumscribed. I'll just write it as well circumscribed skin lesion. If I'm going to be talking about a vesicle would be something very similar, just that it would be less than 1 centimeter, in size. So these are a few terminologies which I would want you all to know before I proceed with this lecture today. So when I talk of this, when I talk of any obstetric disorders, at that point of time, obstetric dermatosis can be of two types. It can be of two types. One, that are exclusive to pregnancy, which are basically occurring because of pregnancy, whereas the other ones are just coinciding with pregnancy. So these can occur in any adult, in any person. They just have happened to occur during pregnancy as well, whereas the first ones are the ones which are exclusive to pregnancy. So when I talk about the ones that are exclusive to pregnancy, there are a few of them. The first one is going to be pemphigoid gestationis. It's an autoimmune disorder. I'll be talking in detail about it इसके बाद में. The next one is pruritic urticarial papules and plaques of pregnancy. It's a benign lesion. And then we have a group of disorders which comes under atopic eruptions of pregnancy. इसके नीचे और 3 disorders आएंगे. I'll be talking about it later. There's one more that I'm not really going to be focusing much on, and that is IHCP. IHCP is intrahepatic cholestasis of pregnancy. It is not a very classical, it is not a typical skin lesion. It is instead a liver disorder, we all know, in which there is an increase in serum bile acids because of progesterone of pregnancy. The bile acid, the bile tract, the peristalsis of bile tract, not peristalsis, the movement of bile tract reduces. So bile acids, bile salts are not excreted through the stools, and they tend to accumulate in the serum. They tend to accumulate and they settle beneath the skin. When they settle there, वहां पे they irritate the mast cells, and the mast cells break down, and these mast cells release histamine. This leads to multiple episodes or severe episodes of pruritus, itching throughout the body. This leads to scratch marks and rashes. So IHCP by itself doesn't cause any specific signs on the skin, but the rashes, the scratch marks and everything that are caused because of the deposition of bile acids is what makes it something that is very exclusive to pregnancy. I'm not going to be talking much about it. The treatment for IHCP is going to be UDCA, sodium-oxycholic acid, which is something that is going to bind to these bile acids and going to throw it away. Or you can also give these women, and you're also supposed to give these women antihistaminics to reduce the itching. What I'm going to be focusing on are the other lesions. When I talk of the ones that are coincident with pregnancy, मेरे पास सबसे important इसमें आता है टीनिया corporis और टीनिया cruris. The other one is acne vulgaris and psoriasis. There are many other conditions. These are basically the important ones that I'm going to be talking about. There is also pyogenic granulosa, but I'm not going to be talking about it today. So when I talk about the main ones, यहाँ पे the first one that I come to is this one. Now this is what I spoke of in the first instance, that is pemphigoid gestationis. Now pemphigoid gestationis, or I'll just call it as PG to make my work easier. It is a very classical autoimmune disorder. Now what happens in it? सबसे पहले तो देखो यहाँ पे lesions, they are surrounding the umbilicus. They have completely taken over the umbilicus, and they are also present all over the trunk. Also, they are present on the arms. They are also present on the arms, and you can see that there are vesicles and bullous eruptions that you can see over here. यहाँ पे these eruptions are not that prominent, but they are very prominent on these hands, and these look very similar to what we call as herpes. So the herpes disorder, which is caused by herpes simplex virus, these are looking very similar to them. Hence, this was earlier also called as herpes gestationis. That is basically herpes of pregnancy, but that is a misnomer because this is not actually caused by herpes virus. This is caused by an autoimmune disorder. Hence, it was earlier called as herpes gestationis, but it is no longer called that. Now it is called as pemphigoid gestationis. How does this occur? Why does it occur? I just mentioned that it is an autoimmune reaction. So basically, antibodies are being formed against collagen 17. So collagen 17 has two antigens. They are bullous pemphigoid 180 and bullous pemphigoid 230. Of them, 180 is the more important one. ये वाला ज़्यादा important है. So antibodies attack against these antigens, and this collagen is present in three major locations. The first one is going to be your subdermal layer, or subepidermal layer rather, I'd say. So basically below your epidermis. So subepidermis. It is also present in your amnion, that is your amniotic membrane. And it is present in syncytiotrophoblasts. So in the placenta technically. Because of the presence of this in the amnion and the syncytiotrophoblasts, this autoimmune disorder is known to affect pregnancy as well. So apart from the mother getting these lesions that I just spoke of, which consists of pruritus and papules and bulla, it even affects the fetus, and because it has affected the placenta through syncytiotrophoblasts, it leads to defective vascularization of the fetus, and that leads to fetal growth restriction. Also, because it is affecting the amnion, it can lead to premature preterm rupture of membranes and preterm labor. So the baby will be born before time, and it will also be low birth rate. It will have problems that occur with preterm baby. So these are the two different spectrum, rather the two different spectrum of the same disorder, in the way it can affect the mother and the fetus both. Now, given that it is causing antibodies that have to be attacked against that antigen, the treatment, the diagnosis, first of all, the diagnosis, the best modality is to do a skin biopsy. I do a skin biopsy of the lesion. I do two things of it. एक तो मैं उसका histopathological examination करता हूँ, and secondly, I do direct immunofluorescence of it. Histopath पे I will be seeing three cells, LEH. L is lymphocytes, E are eosinophils, and H are histiocytes, that are tissue-specific macrophages. Whereas in direct immunofluorescence, now because this is an antibody-antigen reaction, I will see depositions of IgG, that is the antibody, and also deposition of complement C3. So immunofluorescence पे, if I'm going to be seeing these two things, IgG and C3, complement 3 deposition, I have to be very sure that this is a case of antibody induced skin and skin disease, and it is going to be pemphigoid gestationis. Obviously, given the fact that it is an autoimmune disorder, the treatment is going to be मेनली सबसे पहले सिम्टम्स को ट्रीट करो, एंटी हिस्टामिनिक ड्रग दे दो, विच इज द सेफेस्ट एंटी हिस्टामिनिक इन प्रेगनेंसी. इट इज क्लोरफेनिरामीन. It doesn't even cause drowsiness. So chlorpheniramine can be given twice a day, even can be given during the day. That is more important. So CPM, most importantly, antihistaminic. Secondly, you have to, the main line treatment for this is going to be topical corticosteroid. So mometasone आता है and आता है clobetasol. Apart from that, if this doesn't work, then I will have to go ahead with oral corticosteroid, and that is prednisolone. How is it given? It is given 0.5 to 1 mg per kg per day. So around 40 milligram per day, and that is to be tapered over time after delivery when these lesions go down. If even this doesn't work, I might have to give immunomodulators. Immunomodulators like infliximab, which is a tumor necrosis factor alpha inhibitor. So infliximab can be given to these women. So basically the antibodies have to be removed from the body. So this is what can work for these patients. Now, if even this fails to work, the other line of management can also include giving IVIG or doing plasmapheresis. Why IVIG? IVIG basically is intravenous immunoglobulin. So if this immunoglobulin is going to go and bind against the IgG that is formed against the collagen, and it will bind and pull it out, and it will not let that IgG affect these antigens. Plasmapheresis is basically something like hemodialysis, but wherein you remove all the antibodies from the body. So these are the lines of management for pemphigoid gestation. Is note that one difference over here, that it is including or it is involving the umbilical area, which is the differentiating point from the next disorder, wherein your umbilicus is completely spared. These are all classical presentations. You may or may not find them, but classical अगर picture आए exam में तो यही बात करना है. So the classical picture wherein the umbilicus is spared and you can see that all your stretch marks जो है उस area में lesions present है, and this is PUPPP. What is PUPPP? Pruritic यानी खुजली. Urticarial. Urticaria is basically redness and itching, a lesion reddish, which is red, which is circular and has itching on it. Pruritic, urticarial, papules, and plaques of pregnancy. This is a benign disorder. Why does this happen? There are hypotheses. There are no pathophysiology. इसमें बस सोचा गया कि शायद ऐसे होता रहेगा. So the first hypothesis is, it says that whenever the skin stretches, यहाँ पे जो stretch marks आ रहे हैं, this stria gravidarum, when it stretches that thin, the collagen inside is exposed to the outer environment, which leads to an inflammatory reaction. So that is the first. That is, skin stretch is one of the first reasons why it occurs in these regions. Secondly, it is said that there is excessive in patients who have increased progesterone quantity or hypersensitivity to progesterone, hypersensitivity or increased sensitivity to progesterone. Now, why should that happen? There are women who are consuming progesterone supplements because they are probably in IVF conceptions or precious pregnancies, or women who have twin gestations. Twin gestation है, बड़ा ज़्यादा placenta है, that excessive placenta is secreting progesterone in ज़्यादा quantities. This leads to the development of these lesions. Apart from that, the third one is an interesting one that we call as fetal microchimerism. Now, what is fetal microchimerism? Now, you must have heard of a test called as NIPT, non-invasive prenatal test. So in this, you test the cell-free DNA that comes from the fetus. So basically, fetus के जो cells है, they do come into the maternal circulation in some amounts. उसमें से जब DNA separate होता है, you test it for NIPT. But यहाँ पे NIPT की बात नहीं कर रहे. यहाँ पे हम लोग fetal microchimerism. Basically, the cells that are coming from the fetus, which are foreign to the mother, because they contain the paternal antigen, they come and deposit in these stria. वहां पे antibodies come and they act against it, and it leads to these reactions or these lesions which are found around those stria. Those lesions which are going to be there, they are going to be very small. See, you can see that these are very small lesions. So they are going to be 1 to 2 mm, but less than 1 centimeter papules, which are Sparing the umbilicus. So peri-umbilical sparing will be classically seen. Also यहाँ पे face का involvement होगा. I forgot to tell that in pemphigoid the face will mostly be spared, but यहाँ पे face का भी involvement होगा and extremities are involved in both. मतलब पेरी इसमें भी था, पहले वाले में भी था और इसमें भी है. Extremities are involved, hands and lower limbs. How do you treat it? Given that this is a somewhat like an autoimmune disorder, एक तो डायग्नोसिस में स्किन बायोप्सी अगर तुम करोगे तो उसमें ज्यादा कुछ दिखेगा नहीं. कभी कभार लो अमाउंट्स ऑफ लिम्फोसाइट्स विथ इओसिनोफिल्स दिख सकते हैं, but very unlikely. The diagnosis मेन हिस्टोपैथ अगर करोगे तुम लोग, उसमें हिस्टोपैथ विद एलाइजा अगर करोगे तुम लोग, एलाइजा प्लस डायरेक्ट इम्यूनोफ्लोरेसेंस, वहां पे यू विल नॉट सी IgG and C3 deposits. So basically, this is a differentiating factor between this and pemphigoid gestation is wherein there is not going to be any presence of IgG or C3. कभी कभार रहेगा, but the quantity is going to be very low in comparison to pemphigoid. How do you treat it? Again, I have to give antihistaminics plus topical corticosteroids. The moment the baby is delivered, the skin stretching goes away, the progesterone withdrawal comes because the placenta is removed, and fetal microchimerism, those cells die away within a short span of time, and hence the patient gets relief after delivery immediately. The next one that we are going to be studying today is going to be AEP, that is atopic eruptions of pregnancy. Atopic eruptions of pregnancy. Now atopy मतलब क्या? You have heard atopy earlier, जहां पे तुम लोग एलर्जीज की बात करते हो. So allergic rhinitis or people having allergy to some type of food or the skin being sensitive to a type of pollen or grass. So we call it atopy. Basically, these people are allergic. So these are all allergic reactions that occur classically in pregnancy. So we have three types in them. The first one is eczema of pregnancy. My bad, sorry. This one is eczema. So over here, eczema of pregnancy. The second one is prurigo of pregnancy. And the third one over here is folliculitis. Pruritic folliculitis भी इसको बोलते हैं. What is the difference? Eczema में सबसे पहले तुम लोग देखोगे that there are going to be itching lesions which are going to be there mostly around joints वाले areas में रहेंगे, और skin folds जहां पे है they will be present in those areas. There will be dry red scaly patches, scales रहेंगे in this area. How do you differentiate from tinea? Tinea में you will see central clearance. दो यहाँ पे you can see, यहाँ पे तो clearance नहीं बोलेंगे, ये जो बीच में पूरा है इसमें, तो इसमें एक तो central clearance रहेगा, plus tinea regions are going to be more or less circular or somewhat circular in shape, and they'll be more red on the peripheries than inside, and once they heal, they leave behind a hyperpigmented, a dark spot whenever tinea lesions heal, whereas when they heal, they won't leave such a lesion behind or such a hyperpigmented spot behind. Eczema is basically itching, just itching because of atopy. Prurigo, in this you will see 1 to 2 millimeter papules, mostly on extremities. Extremities पे classically दिखेंगे prurigo. You will see a lot of women. This is much more visible in women who have a lighter complexion or whiter skin. But in darker women or women who have slightly darker skin shade, in them you would not be able to appreciate them. But in Indian population, the wheatish complexion that we have, you will be able to see a lot of women with these eruptions on their legs. It is more to do with atopy. Now, the common thing with all these three disorders is that if you ask them, they will tell you some history of, like, they get up every morning and they have few sneezing episodes. They've been having it since several years. Or whenever they go to a park or something, they often start sneezing. So they will give those classical histories wherein they have allergic component to them. They are allergic to something or the other. So atopy in their history is a very significant pointer towards what these lesions are. Again, all these lesions are benign. They have no problem. They have no effect on the outcome of the pregnancy to either the mother or fetus. Folliculitis is very similar to something that you get when you shave off something, when you shave off your hair from your beard or your skin, or you just pluck off one hair follicle. At that point of time, you see a swelling and inflamed swelling that comes over there. So this is very classical to that. But the main point over here is that these lesions are going to be slightly bigger than prurigo, and they are going to be more so on the trunk of the body. These are very rare. Again, for all these three, the treatment is mostly अवॉइडेंस ऑफ एलर्जेंस, तो जिससे भी एलर्जी है उससे थोड़ा दूर रहो, घास वास पे जाके सोना नहीं है, पॉलन के एरिया में रहते हो तो थोड़ा दूर रहो, खिड़की बंद रखो ड्यूरिंग द ऑटम सीजन. एंड सेकेंडली एंटीहिस्टामिनिक्स. Again, you can give these women corticosteroids if the symptoms are too severe. Topical as preferable. This one is an important one. In this, I have shown generalized psoriasis of pregnancy. Now you can see over here that these lesions over here, you can see the green in color. Plus there are red lesions very specific of psoriasis. Now you have seen psoriasis, you must have seen a lot of cases of psoriasis. You must have even seen psoriasis in your family. A lot of people have it. It's an autoimmune disorder in periods of stress and in extensor compartment जहाँ पे friction होता है, abrasion होता है. These lesions are seen more commonly. There is hyperkeratosis. Basically there is a hard layer, there is a hard scale of skin that is formed on these lesions, which is very classical. And when you peel it off, there are bleeders that can be seen beyond it. Obviously, you don't peel it off, but that is very classical of it. So here you can see though that these are very greenish in color. These lesions are very greenish in color if you can see over here. Throughout the entire abdomen, these are very greenish in color. The reason being these are infected. Now what happens is women who have psoriasis often, and not often I would say, or rather occasionally, these women end up getting a very severe form of psoriasis. In this what happens is that there are psoriatic plaques developed, vesicles first. These vesicles are just watery, water-filled, they're just water-filled small enlarged lesions. These vesicles eventually, after a period of time, they become pustules. But these pustules are sterile because they are not yet infected. But after a period of time, when they start bursting, they get infected and they become infected pustules. Now these infected pustules, if they are infected, you would know that whenever you have sputum that is green in color, or whenever you have vaginal discharge that is green in color because of trichomoniasis, or the skin lesions, anything that comes, your wound gapes, your surgical site infections of your cesarean wounds, whenever they give out a greenish discharge, you know that there is some infective agent. Most probably it is Pseudomonas. So when it becomes infected, this greenish tinge to it occurs. Now when this occurs, this infected pustules occur, the female has multiple such pustules, and before they dry up, the female, just like in a female or just like in a patient who has sustained burns, the patient with burns loses a lot of fluid through all these lesions. So these women are often subjected to hypovolemia. They lose a lot of fluid through evaporation from these lesions. Also, they lose a lot of proteins from this. So there is also going to be hypoalbuminemia. Now these two things end up reducing the fetal blood flow. So whenever fetal blood flow is reduced, there is going to be fetal growth restriction and even possibility of IUFD. These women have to be typically cared for, admit करके, probably in an ICU setup if required. The treatment for them is सबसे important है, इनको IV antibiotics देना है और वो broad spectrum देना है. So broad spectrum IV antibiotics are given. After that, you start these women on topical corticosteroids like mometasone or clobetasone. If that doesn't work, after that you have to give them oral corticosteroids. If even that doesn't work, you have to give them immunomodulators. So immunomodulators that you shall be giving them are classically going to be infliximab and adalimumab. And these patients have to be maintained on it. You can also be giving something like cyclosporin to them. Steroid sparing agents, they reduce the dose of steroids that is required. Once you terminate the pregnancy, now also because pregnancy was an altered immune state, your immunity goes down to tolerate the fetus which has a paternal antigen. These flare up during pregnancy. Once the patient is delivered, she will still have psoriasis throughout her life probably, but she won't have such flare ups, whereas this is what is occurring to her. So the treatment is to only keep it under remission as long as you can. The next lesion and the most favorite one of ours is going to be tinea corporis. You would ask me, why am I discussing something that we have treated even in our MBBS? The reason is, यहाँ पे by the way, see the lesion, periphery में, there is maximum redness, inflammation. The inflammation is because of the cell wall of fungus, that is chitin. So tinea corporis caused by Candida albicans or Candida glabrata or Candida tropicalis. The latter two are resistant species. ये लोग resistant होते हैं, whereas albicans is a friendly one, वो easily चला जाता है. When this starts healing, this central patch that you can see will start turning like normal skin, but a little hyperpigmented, and it is, whereas this periphery is going to spread out even more and affect more areas. So why am I discussing this? The reason being the drug that we give to these women. Whenever I see it on this area, the first drug that I have to prescribe her is going to be luliconazole टॉपिकल एप्लीकेशन क्रीम. इसको कांस्टेंट रखना है, याद रखो. टॉपिकल एप्लीकेशन के लिए क्रीम लेना है. लोकल एप्लीकेशन या टॉपिकल एप्लीकेशन ट्वाइस अ डे वर्क्स. The problem is with the oral drug that we give. A lot of people give tablet fluconazole. Now, fluconazole, an antifungal drug, is category C. Category C drug है in pregnancy का safety categories of FDA. Whereas another drug called as terbinafine, which we don't actually give too often, is category B. They say that fluconazole having a long life, having a long half-life, you just need to give one stat dose of 150 milligram. So that the advantage of this is compliance, but it is of a lesser safety grade. Also, they say that there is a higher concentration that is achieved in these lesions when I'm giving fluconazole in comparison to terbinafine, but the safety is in question here. So I would still recommend that you prefer to give tablet terbinafine in dose of 250 mg twice a day for 7 days for these lesions because it comes under category B. A little talk about vulvovaginal candidiasis. Basically, if this candidiasis is going to occur in the vagina and the surrounding area, the patient will have splash dysuria. Splash dysuria is basically whenever she micturates, whenever she passes urine, because of the local inflammation, again because of the chitin cell wall component, she will have burning micturation. Apart from that, she's also going to have redness around her labia majora. How do I treat it? The first line drug is going to be local clotrimazole 100 milligram. For 1 week, you can give clotrimazole पेसरी आता है अंदर डालने के लिए, कैंडिड पेसरी भी उसको कहते हैं, और you can give tablet fluconazole because they say that terbinafine doesn't really reach in those concentrations, so you can give one stat dose of fluconazole. So that is how you treat vulvovaginal candidiasis. If it is happening in a gynec female who is not pregnant, and if it is resistant, if it is recurring, then you send in a swab to check which candida is growing inside and what is it sensitive to. Also, you can give them a suppressive therapy of fluconazole 150 milligram once per week for 6 months. So that is how you treat it in a female who's not pregnant. So that is a bit on tinea corporis and tinea crura and vulvovaginal candidiasis. There were a few more things like pyogenic granuloma, wherein there is a growth in the gums that occurs in pregnancy, but I'm not talking much about it. They are not even that common, but these are the major disorders that you will see in pregnancy of the skin, and that is it. I hope you understood this lecture and you would be able to at least diagnose these patients better from now on and would not rely on others to tell you what the diagnosis is. It really helps to be the one who knows the diagnosis, and all you need is someone's assistance, whether I have to treat it in this way or not. So to rely completely on someone else to tell you what is it is really something I find embarrassing. So I hope you understood this chapter, and I shall see you again in next week's OBGynugget. Signing off, Dr. Aditya.